If you would, you've got another mind map at this point, or concept map. It's the one labeled cancer treatment. So let's go ahead and pull that one out now. Over on the far left, we're going to start with surgery. Surgery for a cancer treatment pretty much starts like any other surgery. It starts with pre-op. With pre-op, we have very known and specific problems. We talked about those, and we'll come back and look at that again in just a moment. We also have the post-op time period after surgery, and we're going to look at the reasons for surgery. Pre-op, our biggest problems preoperatively are anxiety, fear of the unknown. These patients basically have a knowledge deficit, so we need to let them know how the day is going to proceed, what's going to happen, who's going to do what. Give them as much information as you can on what's going to happen in that pre-op and post-op setting. We begin teaching them things like how to cough with using a pillow, how to control pain. All of this is something that we have to address with that knowledge deficit related to pre-op and what the patient's going to experience. In the post-op area, for those of you that have been to PACU, you know your major problem is ineffective airway clearance. They just aren't breathing the way they're supposed to. Their respiratory effort may be less than what you would like, or it may be non-existent depending on how heavily sedated they come out, and we may have to provide some type of recovery for that patient, either chemically or doing manual ventilation until we can get them where we want them. We may be using some adjunctive devices like a nasal cannula, a simple mask, or a non-rebreather. A couple of different options I'm sure that for those of you that have been to PACU have seen. As we continue post-op, some of these same problems, this ineffective airway clearance, they don't want to turn, they don't want to cough, they don't want to deep breathe. These are things that we have to work with. Pain is always a problem. Everybody wakes up and, you know, I'm in pain. We can have fluid volume deficiency or fluid volume overload. These are things that we need to watch for in these post-op clients as well. Reasons for surgery, there's 3 reasons. Again, we talked about those. We're going to look at them again just very quickly. The curative, so we can remove whatever the cancerous agent is, tissue is, and we're done. Palliative, we're trying to remove enough of the material that they experience pain control perhaps, and then debulking to make for smaller tumors that have to be treated. Chemotherapy is another treatment option. Some of the most common side effects are nausea, vomiting, diarrhea, and constipation. These are major problems for our patient with chemotherapy, and we're going to look at some of the things that we can do, some of the problems associated with that. Chemotherapy, we also need to look at pain, alopecia, that hair loss, bone marrow suppression is going to be another one. As we look at bone marrow suppression, we know that there are some complications of it. We can have a decrease in the number of white blood cells. There should be a decrease arrow in front of white blood cells showing you that they're declining, and that leads to a risk of infection. We can have decreased red blood cells, our hematocrit and hemoglobin numbers are dropping. We can also have decreased platelets. When we have a decrease in platelets, remember our patients at increased risk for bleeding related to an injury. So we may need to suggest some things that will help reduce those injuries, help reduce the number of instances they get into that bleeding may be an option. Again, switching over to an electric razor, for example, should make the patient less risk of being nicked for while doing activities of daily living. Some of the other things that we need to look at with patients with decreased platelets, we need to be looking at our lab draws. So if we're drawing labs from a patient, we need to make sure that there's not a way to get that without actually having to stick the patient again. So if our patient has a central line, a CVL, a PIC, or a peripheral IV, can we draw labs from that line as opposed to sticking the patient again? Not only is the patient at increased risk for bleeding as a result of that procedure, but we've also added another opening into the skin, which is increasing their risk for infection. So lab draws in and of themselves have several complications, and so we need to really do an assessment of that patient before we do that lab draw and say, hey, is there some other way for me to get this lab other than having to stick this patient again? Decreased red blood cells, hematocrit, and hemoglobin lead to impaired gas exchange. There's just not enough red blood cells in there to carry the oxygen that we need to have our activities of daily living performed without being just totally overloaded, overworked, fatigued. Um, we have ineffective tissue perfusion, so you may check their cap refill at their fingers and notice it's delayed. They have activity intolerance. Again, they won't want to get up and walk over to the bathroom commode because it's so far away. So we can help maintain their independence by giving them a bedside commode. For females, a urinal for men, or even a bedside commode for stool movements, that kind of stuff. Keep that in mind. What can I do to decrease this person's overall energy expenditure? Another thing too, again, remember with these decreased red blood cells, hematocrit, and hemoglobin, we may be looking at drugs like EPO to increase the number of RBCs in circulation so that the patient has a better chance of having enough red blood cells there to carry the oxygen that they need. Nausea and vomiting, let's look at that because it's in of itself is